Earlier in the day, we looked at health systems resilience assessments for India and the UAE, as well as the challenges and opportunities in designing better surveillance, alert, and response systems. And now I think we turn to a very important session on climate change and health. So I will pass the time now to Iman Fahim Hamid, Senior Consultant at Access Health, who will take us through the session. Iman, over to you.
Thank you, Tim. Good afternoon, everybody. I hope you're well filled for the second half of the day. Now, over the past year, with the increasing focus on climate change, we thought it pertinent to begin to really look at that within the Global Learning Collaborative as well. And does this work? Slides, please. Thank you. So we began last year to scope our journey in climate change and health. And two first questions that we really had was, what has been acknowledged and what's less clear? Next slide, please. This isn't responding. Okay, so the climate crisis is real, and the impacts of climate change on health, both directly and indirectly, is well understood. What's less clear is, should climate impacts on health be prioritized over other health needs? And this is especially relevant in countries which have fragile health systems and also the double burden of disease. And secondly, who in the healthcare system is really responsible in addressing these impacts and at what levels? And then finally, where does this responsibility end for a health system actor? Does it stop with just continuous health systems services, or do health systems actors then need to begin thinking about working with other actors and agencies to address upstream determinants? So, using a modified Johari's window as a learning tool, because this is a global learning collaborative, I thought we'd bring in a little bit of theory about learning as a tool. Using this window of listening, really, to plug the gaps in the knowledge, where we look at experts or people with technical understanding versus people who are from communities and lived experiences, trying to understand what the blind spots versus the hidden area. The blind spot is basically where experts have an understanding, but this understanding is not communicated to the people who have lived experiences, versus those who have lived experiences who might have a better understanding of things, but technical experts aren't really looking at the problem. And then finally, where there are areas where neither are really understanding a problem. So the problem that exists isn't being acknowledged for being actually, in existence. And hoping that through addressing this cyclical three-step area, we move into the open arena of complete understanding. And the reason why I bring this up as important is because often we talk about silos. This is why we have silos, and this is why we have gaps, because we don't really have a process of iterative, patiently really plugging in and listening. So moving on, this led us to more questions, right? So we began by listening to the communities who are at the receiving end. Are there different ways in which some groups of people are affected by climate change in comparison to others? And what do they know and understand that we as technical experts do not from a health perspective? And by answering these two questions over time, we hope to really understand how we can build health resilience with communities and not really for. And what that means is really to have a bottom-up approach that informs the top-down policies that we have. So over the last year, we spoke with Pacific Islanders, researchers who work with Pacific Islanders, small-scale fishing communities, and this is to represent people who are environmentally linked in terms of their occupation, with women and children, and we'll be having more conversations on this today. And we hope to then extend and continue with other groups such as migrant workers, LGBTQ, people with disabilities, and so on. two points that we found was a consensus in all these conversations was that communities are not victims, they have agency, and it's just often that even if they can actually help themselves, they don't really have the means to do that, that needs to be supported. And two, respecting that knowledge and bringing that knowledge up into the decision-making process, having the processes to really capture that knowledge. And so I'm going to now move on to what we've been doing this year, which is really taking all of those conversations and then looking at the frameworks that are in place to build health adaptation policies. And what we did was we began by looking at a tool that was used to create the Pacific Island Health Adaptation Plan, because that in itself has also reviewed several other climate adaptation plans. And we've modified that with 4 main pillars that we think. We've included vulnerable communities as inclusion, because although we talk about localizing contexts, we assume that the context is geographic. But communities can actually identify in different ways within a same geographic distribution. So you might actually have health services serving a given area, but that area can actually have communities such as farmers, fishermen, and they have different structural cognitive barriers that predispose them to health impacts in a different way and climate impacts in a different way. And so without understanding that, we can't really plan to mitigate those effects. So we took a look at South Asian countries and Southeast Asian countries, 4 countries to begin with, and we found that in these adaptation policies, there were 3 major gaps. One was health systems assessments, health workforce resilience, and how comprehensively they're looking at defining who these vulnerable communities are that they serve. So this is a busy slide, but the main takeaway, right, is that if you want the health system to begin to understand what the problems are on the ground, you need the health system's actors to understand how to do that. And you have to have a process to do that. We don't have that. It's not well fleshed out, and we don't have the indicators that we would need them to really do. So really understanding that is either partial or it's not included. And then health workforce maintenance. Having the capacity and allocation of health workforce to be able to carry out climate resilience planning. And at what level? We don't really know how well defined those are in these countries. And in terms of vulnerable communities, you can see that you've got partial coverage of women, children, the young, the old. But you can see that a lot of people with chronic health needs, people with disabilities, and the LGBTQIA are not considered at all. So when you mean partial, they identify them as climate risk, but they have no further provision to capture what those unique risks are in these communities. So this makes a nice segue into today's session. The reason is we were talking about operationalizing things this morning. We were talking about localizing. We were talking about breaking silos. And so how do we really do that? And I think in the disaster risk resilience management community, they've been doing this far longer than maybe the health systems actors are hoping to do at the intersection of climate and health. So I'd like to introduce our first speaker. We'll have 2 case presentations as a means of understanding how people work with communities, how people work with communities' different perceptions and understanding, and bringing that inclusive knowledge into the planning process. And also working beyond the health system itself into external infrastructure resilience. These are the 2 case presentations. So I'd like to invite our first speaker, Ms. Whitney Mills, currently a regional resilience specialist at Waikato Regional Council. She specializes in assessing natural hazard risks and fostering resilience in the Waikato community. She was influenced by her lived experiences of climate hazards while growing up on a dairy farm in rural Northland, New Zealand. Her primary focus is on climate change-induced risks, collaborating with communities to contribute to local and national resilience strategies, and Whitney advocates for proactive mitigation and adaptation, showcasing New Zealand's practical approaches and promoting informed decision-making. Over to you, Whitney.
hear me? Awesome. Kia ora koutou katoa, ko Whitney tōku ingoa. I am the Regional Resilience Specialist at the Waikato Regional Council in New Zealand, a local government organisation which governs the management of natural and physical resources in the Waikato region. Today, I'll be highlighting New Zealand's approach to adapting to climate change and touching on a few of the key lessons and challenges that we come across when actually undertaking this community-led adaptation work. In 2017, the Ministry for the Environment released the Coastal Hazards and Climate Change Guidance for Local Government document, which is a framework that supports local government to plan for climate change by following a 10-step community engagement methodology known as Dynamic Adaptive Pathways Planning, or as we call it in New Zealand, DAP for short. DAP is an engagement methodology and has been applied in New Zealand particularly for adapting to coastal hazards currently, but it's essentially just a framework for proactively identifying a series of decisions and linking those to potential strategies to mitigate risk. It is a continuous process of assessing risk, evaluating the effectiveness of actions taken, and adjusting those as needed. By adapting to the unavoidable effects of climate change, we become more resilient for our future. This process helps us plan for the what-if scenarios. This approach maintains a certain degree of flexibility, so as conditions change, such as sea level rises faster, or hopefully slower than what is projected, the community haven't necessarily locked themselves into a single strategy, but has identified different options to maintain their flexibility. Basically, this methodology forces us to become comfortable with the uncomfortable. DAP can be applied across multiple different disciplines of climate change, including what we're talking about here today, the health system resilience. The only part of the engagement methodology that will be extremely different would be the what is happening phase, where you would assess risk and community risk thresholds for your community on health issues compared to myself who would assess it on natural hazard risk. Next slide. There you go. In the Waikato region, we've applied DAP to two separate parts of our coastline in collaboration with our local district councils, but most importantly, our community and our local iwi. The Wharekawa coast is located just south of Auckland on the western side of the Firth of Thames. This piece of coastline is extremely low-lying and is already at current sea level. In 2018, the community had a significant coastal inundation event. This event triggered the community-led adaptation process where we work alongside the community and the local iwi to plan for a resilient community for the next 100 years using the DAP process. Now I'm going to show you a video that we've created for the process, for the project, that will talk further about what we've done.
In January 2018, we had a monster storm. Combined with the king tide, the sea invaded the lake.
In the morning we got up and the waves were breaking down our driveway. I came upstairs and I could see the water coming in from behind us. So the rainwater was coming down the hills, the seawater was coming in the front, and we could see it rising above on the fence line.
And then when the waves retreated, the farmers came out of the hills with their tractors and cleared the roads for us.
Although it was very devastating, it was beautiful to see the community come together and roll up their sleeves and help everybody out.
It wasn't the first time it's happened. Only a year earlier here in Waikato, the bridge got washed away in the southern end, and in the northern end was a slip which cut us off completely.
We knew the community couldn't last as it is with the projected impacts of climate change. However, we didn't know when these changes needed to be made to keep that community resilient in the future.
So in the last 30 years, there's been several attempts at trying to solve the problem. None of them have been really successful, and it's left a little bit of ill feeling in some parts of the community.
But climate change is a real risk, and the community saw an opportunity to build a stronger relationship with the council and to build a better future for ourselves.
So we're here, we've experienced it, we see it, so rather than sit back and complain, we rallied together and we formed a community panel so that we could build rapport again between the community and the council.
So we needed the community to make their own evaluation around their risks to coastal inundation and flooding.
We got some good literature to give to the people.
We compiled a lot of information. Basically, we assessed the impacts of coastal inundation and freshwater river flooding for 2 event scenarios. We then condensed all this information and gave it back to the community and asked them to assess the community risk thresholds for these impacts.
It was good because depending on where you lived, you got your own assessment. Now, things differ up and down the coast.
For some areas, like here in Kaiawa, the risk thresholds have already been met.
For the other areas, we used climate change projections to see when these thresholds could be reached in the future.
We knew our risks, but getting a glimpse into the future has given us further thought.
We know where the work needs to be done now and a timeline on how to prioritise the other areas. We know that nature's going to do what she wants to do. We want to contribute to the long-term plan to build a sustainable future for those who live here today and for those who are yet to come.
Awesome, thank you. So now I'm just going to highlight a few of the key learnings and challenges that we faced when we undertook this community-led adaptation process. I won't go into them all right now because of time, but I will be happy to elaborate them further with a discussion later. Why is this not going? There we go. There we go. So first off is your community is your greatest knowledge holder. In New Zealand, Mataranga Māori is the use of Māori knowledge passed down through generations. It focuses on sustainability. The Wharekawa coast is steeped in history of those who came before them. The council and the community have the desire to leave the area in a better shape for the generations to come. To do so, all adaptation options and pathways have been developed by the community, for the community, and utilises this knowledge passed down from their ancestors. For an example, each body of water has its own life force or spiritual meaning to the local tribes and are typically named after significant geographical features. The main river in the project area is called Huarahi. Hua means to be hurt or cripple, and rahi means to be large or big. So the local river to the local iwi is known as the river that is large and will cripple them, and as a result, they haven't built their livelihoods in the floodplain of that river. In New Zealand, we're only just moving into the phase of implementing our processes because the guidance was released in 2017 and it took us around 3 to 4 years to get to the implementation step. However, speaking from the small part of implementation that I have been involved with, having a strong governance group is crucial to the success and the adoption of your plan, particularly towards central government. Your governance group needs to come along from the beginning and come along for the ride with you and your community so that when you come to adopting your plan and implementing your plan, your governance group knows what needs to be done. Building trust in your community is going to be the hardest thing. As you saw in the video, there was quite a lot of ill feeling towards the council by this community. It took us close to 2 years just sitting down and talking with the community for them to trust us. And how we did that was doing what we call quick wins. These are things that could be done at a short notice and at relatively low cost that make a big impact for the community. And for the Wharekawa coast, this is as simple as clearing a drain before a heavy rainfall event so that the drainage system works as operated. It was hard work and resource intensive, but I believe this is one of the reasons why this process has been so successful for our region. Some of the other learnings that I'll touch on later is around planning and pre-implementation takes longer than what you think. Don't underestimate how much time and pressure your community feel to make the right decisions for their community. This is just a snapshot in time. You'll always need to readjust and reassess. And it requires, as Iman said before, a bottom-up and a top-down approach. And we're all in this together. It's a new multidisciplinary area, so don't be afraid to make some mistakes. Thank you.
Thank you, Whitney. For our second case presentation, I'd like to invite Dr. Ratnesh Kumar, currently the lead specialist in knowledge management at the Coalition for Disaster Resilient Infrastructure. He's a seasoned disaster risk and resilience professional with diverse experience in research, knowledge management, post-disaster need assessment, and has spearheaded global initiatives, including the CDRI WHO program on resilient health infrastructure, and has held significant roles at the National Disaster Management Authority NDMA, India, NBCC, India, and Larsen & Toubro. Mr. Ratnesh, Dr. Ratnesh, over to you.
Thank you, Iman. And so today, here I represent CDRI. It's a Coalition for Disaster Resilient Infrastructure. Oh, sorry. It's a relatively new organization, so after 10 days, we will be completing 4 years. We have footprints in 39 countries, and it has been set up by global leaders to work toward the resilient infrastructure, including health. So for today's presentation, it's good that Whitney has set up the context that the importance of community in when we work toward the resilience towards climate change or disaster. So in this presentation, the boy in the picture is from a very small village called Naga village in Sikkim. And when we think of making a resilient health system, so can we imagine that how can we make our health system resilient for a community like this? Now, so this photograph was taken by myself, and if you see this village as of now virtually does not exist on the map because it was devastated by a GLC4HSR's event, flash flood triggered by glacial lake that happened in Himalaya. So basically what happened is due to impact of climate change, a glacier has melted into a lake, huge lake, and somewhere altitude of 6,500 meters. In the intervening night of 3rd and 4th October, the lake burst and it led to massive floods along the river system, the red line you see. And I can say with more conviction because just 10 days before this event, I was traveling across this line. It led to massive damages, a lot of casualty and financial losses, close to $2 to $3 billion in just few hours of flash flood. But such incidents are not standalone. So one of the CDRI biennial report highlights that average annual loss for principal infrastructure sector is close to $300 billion for a year. Now, if we look at the impact of flash flood or GLC4 on climate, on the health system, on one side we see that there is an impact on health, and we have been talking about it. So obviously there are casualties, there are injuries. Those are one of the impact. There are cases of mixed vaccination, delayed treatments, and then the possibility of new diseases emerging. Also, if we visualize that how the health facilities are stressed during the disaster. So if we look at during this disaster, the epicenter where the maximum injuries were reported, the district hospital had to almost 3 times its capacity. And it is this time that rest of the hospitals were disconnected because the roads and bridges were damaged. If we focus on the impact on the health infrastructure, then obviously there are damaged hospitals and there are damaged systems within the hospitals. We had to create new, and so the government had to create new and temporary facilities so that the basic health services can be resumed. And in addition to that, due to disruptions to the roads, power, water, telecom line, sanitation line, even the hospitals which were not affected directly were performing much below or were inaccessible by the people. So when we think of health infrastructure system, it's an interconnected system of other infrastructure as well. So now if we look at the scope of work being considered by the GLC, then the 10 components of WHO Health System Resilience Framework is highlighted here, and one of the component is focused on sustainable and resilient infrastructure. It is this aspect where our program, in partnership with WHO and GIZ Germany, is focused on. So if we see the construct of resilient health infrastructure, then basically there are 3 components. One we are very familiar with, hospital operations, which look into the safe hospital component, the emergency department within the hospital, and preparedness of a hospital in responding to the disasters. The second component is the building asset. Imagine the hospital itself as a building, and then we look into its structural integrity, so that earthquake or something it does not affect. There are non-structural aspects, and then there are functional aspects. So many times what happens that even if the earthquake or something is not very big, the non-structural and functional aspects actually lead to the disruption of the health facility. The third component in the red is the systemic aspects which we need to consider so that disruption to other infrastructure systems does not affect the performance of the hospitals. So considering this construct, we worked with Sikkim government between January to till now, last year, January 2023 to this year, and in between this disaster had happened. So the Sikkim has almost 95% government health facilities, and they are building a lot of new infrastructure, but we identified that there was very little preparedness for the disaster response. And our approach was very government-led, but it was a very consultative process. We had invited more than 12 departments to come and discuss that how different departments within the government system can contribute to building the resilient health system. We identified 4 intervention areas: risk and resilience assessment, capacity building, technical support, and governance and policy. Some of these are self-explanatory, but in risk and resilience assessment, today we are discussing the number of parameters that might be required to determine whether the health system is resilient or not. So we have come across roughly 80 parameters. We are still working on that. For capacity building, it is where we did maximum work, and now more than 500 staff, both doctors and engineers, have been sensitized about disaster response, disaster resilience planning. In the technical support, we have assisted government in rapid vulnerability assessment and also during the PDNA, that post-disaster need assessment. Overall, our aim is to bring all the lessons from the first 3 steps into a cohesive policy framework, policy roadmap, and also help them integrate it with the overall future policies and funding mechanism. So just these are some of the photographs from the field. Obviously, there were many photographs. And so just to leave you with 3 messages, that as we worked on the resilient health system aspect, there is a need for adequate attention to the infrastructure component, because it is where everything is, everything else will function. Also, there is a need to consider the systemic aspects of the infrastructure. And CDRI and WHO have taken initiative to work toward the resilient infrastructure, and we are open to partner with global actors for the knowledge exchange and all. And our aim is to influence the global policy and financing. That's it. Thank you. This is a bamboo bridge which was constructed after the disaster. At this place, there were 2 major bridges, but they were washed out during the disaster, flash flood. Thank you.
Thank you, Dr. Ratnesh. And thank you, Iman and Whitney as well. I'd like to invite 3 of them on stage as we also introduce our panelists for this session. May I invite Professor Lam Ki Po to join us. He is at the National University of Singapore. He is a licensed architect and fellow of the Royal Institute of British Architects. I would also like to invite Professor Mala Rao from the Department of Primary Care and Public Health at the Imperial College London. And she is chair of the WHO CRO's expert group on climate change and health, and she joins us virtually. I would also like to invite Dr. Patricia Schwertel, postdoctoral researcher at the University of Heidelberg, who is a global health academic at the Heidelberg Institute of Global Health. And last but not least, Dr. Renzo Guinto, associate professor at the of Global and Planetary Health at SingHealth Duke NUS Global Health Institute, and he is a member of the Philippine Climate Change Commission's National Panel of Technical Experts and the WHO's Technical Advisory Group on the Ethics of Climate and Health. So I understand that Iman will be moderating the session, so Iman, over to you.
Thank you, Tim. Can you hear me? All right. I think I'm going to start. I'm not going to follow any order to keep everybody on your toes, so not going in order. So I think when we discuss health systems, we've really been used to the conversation on centering people. But, and I'm going to pose this to you, Renzo, how does this need to shift in the climate change and health context? You talk a lot about planetary health approaches, and I'd like you to really kind of bring us into the understanding of why that's important and what that is and what that means for resilience planning as well.
Sure. Thank you very much for this wonderful opportunity. And it's great that we're now talking about climate change in a health sector forum. You know, if you remember in the recently concluded COP28 that was held in Dubai, after 28 years, the UN climate negotiations had dedicated a day for health. There was a health day. We were there, Trish and many other colleagues, and we were able to really position health as an important part of the climate agenda. And then now we need to do the same, putting climate in the health sector agenda, that if we are going to strengthen health systems, achieve universal health care, build resilience to all kinds of threats, we need to make sure climate change is part of the equation. You also alluded to the concept of planetary health. You know, you may be wondering, what's planetary health? We're more familiar with public health, about the health of people. But over the past several years, there's also this growing recognition that the health of people and the health of the planet are inextricably intertwined. In fact, they're inseparable. What happens to Mother Earth, they come back to us in the form of disease, despair, if not death. And so we need a holistic, integrated approach. I always tell my medical students, both in the Philippines and now in Singapore, this is my 4th week here, glad to be here. And I always remind my medical students, in this day and age, we now have 2 patients, not just the people, but also the planet. And so, you know, with this integrated approach, we are addressing climate change and all sorts of pollution to the air, water, and land. Plastic pollution, in particular, is a growing concern. Just last week, I think, in the New England Journal of Medicine, there is an article that showed that microplastic has already been found in, plaques that were detected, in those who had, heart disease, coronary artery disease. It's now flowing in our bloodstream, and plastic is also floating in our seas and in our lakes and in our oceans. So these are some of the, pressing planetary existential threats that we're now facing. And therefore, health systems, as we try to not only strengthen but reimagine how health systems will be designed and operate in the years to come, we need to incorporate this larger, broader, holistic approach, again, that cares not only for the human inhabitants, but also for the planet, the ecosystems, all creatures, great and small, all these wonderful things that ensure our health, well-being, and survival.
Thank you. And I think that kind of segues well into the second question. Is Prof. Mala with us? Okay, yes, sorry. Very confusing with two screens. Prof. Mala, I'm going to ask you, when we talk about vulnerable communities and marginalized groups, we talk about women a lot, but really not enough even then. My question to you is, how does climate change impact women disproportionately, specifically when we talk about sanitation and reproductive health? And how involved should the health systems actors be in preventing and building climate resilient sanitation? So not just talking about, understanding how much worse, how many more numbers of, reproductive related diseases we'll get, and so on, but really how involved should they be upstream? Over to you.
Well, first of all, Ivan, can you hear me?
Yes, I can hear you.
Hello, can you hear me?
Yes.
Yeah, great. Okay. Well, firstly, Iman, thank you so much for inviting me to contribute to this session and to do so virtually. My apologies that I can't be in Singapore with you all today. So you ask how climate impacts women disproportionately in terms of sanitation and reproductive health. Women make up half the world's population, but they also make up the majority of the world's poor. And typically, it is those with the fewest resources who will also be most susceptible to the negative impacts of the climate crisis. Indeed, it's been said that it is the gender inequalities that define women's lives prior to a climate disaster that are really what put them at such greatly increased risk from climate change. Could I have my slides brought up on screen, please? I can't tell whether they're up there, but if I could have number 2, the first of the slide with pictures, I'd be enormously grateful. And if you could let me know, yeah, is that, let me know when that's on screen. It's the first one with the pictures, so it's number 2. It's the second one, please, Miguel. Yeah, thank you very much for that. Thank you. This is the one I was looking for. Now, every aspect of climate change is affecting women in relation to sanitation, hygiene, health, and of course, reproductive health. Here's just one example. Only 3 days ago, a British newspaper reported on coastal Bangladesh, where sea level rise is resulting in increased levels of salt and pollutants in freshwater sources, resulting in women having to walk back-breakingly long distances to fetch a bucket of water for the household to drink. Obviously, if they don't fetch that, then the whole family risks death due to gastrointestinal disease. But bathing in the polluted water is increasing the risk of infection. The women are losing their hair, and it's making it extremely difficult to maintain menstrual hygiene, to the extent that some young women are reported to be putting themselves permanently on the pill so that they no longer face the torment of menstruation in the scenario of very little water, and what little water there is being highly polluted. So, leaving aside health systems resilience and all the rest of it, we aren't even looking at normal physiological processes, that the everyday aspects of life and how those are massively being if you like, damaged or being made difficult by the climate crisis. Menstrual hygiene and access to clean drinking water are massive challenges for the poorest women in South Asia, whether they're working in construction sites in rapidly urbanizing societies. You can see that picture there. And it is women who do the most physically demanding jobs such as stone cutting or carrying bricks, or indeed in farming, although women are the majority of small-scale farmers and produce much of the world's food. Then there is the issue of maternity. And if you look at the picture in the top right-hand corner, the UK charity War Trade published a powerful case study in pictures of what women packed in their maternity bag when they were going to the hospital when in labor. And the picture in that corner shows your mother in rural Africa who has to pack a rubber sheet because there's no water to clean beds between births. And also she has to bring a bucket because she or a companion will have to go and fetch water from a communal resource in the village to wash herself and her baby after the delivery. And this is set to get worse and worse because of water scarcity caused by climate change. Floods have a greater impact on women in relation to sanitation during delivery, but also as the primary caregivers in their household, being responsible for safe water, safe food, and sanitation for the whole of the family. And the UN reports that 80% of people displaced by climate change are women. And just let's think of the risks they face, ranging from access to safe water, sanitation, safe maternity, to sexual and other forms of violence, and it just doesn't bear thinking about. So in my view, health systems, could you show the last slide, please, Miguel? So in my view, health systems, going to your question, your actual question, Iman, have to be involved in developing climate resilient sanitation systems, but this can only be done if gender equality is achieved in terms of equal access to planning, finance, and decision-making in health and in reproductive health systems, but also in the wider socioeconomic system worldwide, because those are hugely interlinked. And Whitney made a very eloquent point about using women's. She talked about traditional knowledge. And here I would qualify that even further and say, please let's use women's strong body of traditional knowledge, whether it's Sikkim, as Ratnesh was talking about, or New Zealand, where Whitney works, or anywhere really. Their interest, women's interest in participating in social networks and decision-making, and their skills in community leadership and willingness to be involved in community development. So, Antonio Guterres said, gender inequality is the unfinished business of our time. And unless we address that to begin with, we can really forget about climate resilient health systems. They're going to remain a distant dream. So I absolutely say, please let's do something about gender equality first and foremost. Thank you, Iman.
Thank you, Prof. Mala. Very, very valid and valuable points made there. And I will return to this when I'm making my closing remarks. And moving on to the next point, I'd like to pose this to Patricia. So in my opening remarks, I talked about how we have the question of at what level of the healthcare system do we need to be really planning and understanding resilience and risk assessments of services. In your experience, what are the considerations that we need when planning a climate resilient health facility at the facility level? Really, because that's where communities need services the most.
Yeah, thank you. Thanks for the question. It's a good question. It might be good just to briefly go over the health impacts of climate change, just for people that aren't familiar with them, just briefly. There's primary, secondary and tertiary impacts, health impacts of climate change, and the primary ones are direct, so the ones probably that we're the most familiar with, extreme weather events, extreme heat, has obviously impacts on our health, but then there's secondary impacts that are mediated through the natural environment, so through our food, water and air systems. Also, that includes the way that climate change will affect vector ecology and change the distribution and patterns of infectious disease. So, for example, we're working in Chad at the moment. They used to have a peak malaria season, and now they're just finding that it's coming at different times, it's lasting longer. The same kind of patterns we're seeing with heat-related illnesses. And then the third least studied area is tertiary impacts of climate change, and these are mediated through social systems. So through changing patterns of migration and conflict. So it is really good to ask yourself in your area of practice, how is climate change affecting the health-related issues in your area now, and how are they projected to affect your health issues that you're addressing in the future, and also geographically, because climate change is affecting everyone everywhere, but disproportionately so and in very different ways. So back to the question about, we're talking now at the WHO, and I'm actually based at Heidelberg University in Germany. We're working on climate change adaptation for health, and there's lots of discussion about climate resilient health systems. And it's very complementary to the health resilience work that's already happening and has a very long history and a lot of evidence, but it there's a need also to mainstream climate change and health across what we're currently doing. So not just thinking about health systems resilience, but thinking about climate resilient health systems. So there's a couple of ways you can approach this. The way that the UN Framework Convention on Climate Change, the UNFCCC, is addressing climate change is through doing what we call vulnerability and adaptation assessments at the national level. And this will develop a national adaptation plan which might have a health component to it. So it's either called a NAP or a HNAP, National Adaptation Plan, or Health National Adaptation Plan. The WHO have also created a number of guidelines to do this at the health systems level. So at a national level, you can do a vulnerability and adaptation assessment to see what are the key hazards that your country will be facing, that they are facing now and in the future due to climate change, and what can you do about that? So it's also very solutions orientated. And what we're doing now at the Climate Action Accelerator, which is an NGO based in Geneva, is doing vulnerability and adaptation assessments at the health facility level. So this is an opportunity to bring bottom-up work with top-down work. So there's a national adaptation plan, but also any health facility from a primary healthcare network to the hospital that we're currently working with in Chad can look to see, with a process very similar to the one that Whitney described, a mixed methods participatory approach to see what really are the key climate change hazards that this particular health facility will face, and what can they do about that. So what we're finding with the vulnerability and adaptation assessment that we've just done in Chad is that the main hazards are around extreme heat, drought and flood. And it brings us through a process, because I think a lot of the health systems assessments kind of conclude often with a checklist or with a conclusion that, yeah, there's a lot of risks here. It's not looking good. So we didn't want to finish with that. So our process also includes a prioritisation activity and an identification of solutions, which is participatory. So the health facility, the multidisciplinary team that we put together say, okay, of these hazards and of our capacities and unique vulnerabilities, we prioritise strengthening our blood bank, for example, because there'll be increased cases of malaria, more frequent throughout the year, and they've got a weakness in their ability to give blood transfusions. Also, a couple of other solutions is just a disaster risk management team at the hospital level and a review of their policies, which they hadn't had before. So some of them are quite low cost and high impact. And another one is that a key consideration or a key concern is that they're working routinely above 40 degrees and in the clinical areas sometimes above 50 degrees. And the chances of the mortality rates for malnourished children with malaria treating in facilities with that temperature are very high. So we're looking at ways to reduce heat in the clinical areas by passive cooling, by solar air conditioning, and through highly reflective paint on the roof. So one thing I also want to add briefly with climate resilient health systems is the WHO have also combined this with low carbon, which is really important. So we don't just think about climate resilience, we also need to combine that with low carbon, because there's an opportunity now to decouple universal healthcare and health system strengthening from emissions, which is absolutely crucial to also address the underlying cause of climate change, which is the emissions. Thanks.
Thank you, Patricia. And I think taking from your point on the importance of low carbon emissions when we move into the health sector planning, Prof. Lam, I'd like to pose to you, how practical is that for countries with, very low capacity to finance complex solutions? Is it possible to really build environments that can still be affordable?
The short answer is yes.
How then?
Well, I think, first of all, thank you for inviting me. As has been introduced, I'm an architect, but I have always been very interested in designing for people, what we typically would call people-centered design. And I think that's been motivating me for quite a long time, which led me to a lot of this interdisciplinary work that has been shared by the other speakers to really try and work together to address some of those issues that are challenging us. I think the first point is, if you could pull up that slide. Yeah. I think this slide speaks a lot to cutting across all those excuses, sometimes I call them. Oh, I can't do this because I'm not in that situation. There will always be reasons why something cannot be done. But I think what we need is one good reason that why we have to do it. And one of the good reasons is this, that despite the challenges that COVID have posed to the world, doesn't matter you're rich or poor, developed, underdeveloped, we all face this. We are all affected by this air quality issue. And it's, without doubt, this is a result of human activities. This COVID proved to us beyond doubt that it's us who created the problem in the first place. So I think that's a very basic lesson to step back and ask ourselves, right? What is it that we are doing that is causing this issue? If we can stop doing those, we will save money. It's a very simple math. There are so many lessons that we somehow are hard-pressed to learn, you know. In today's globalization, economies are still enamored with, and rightly so, it's not a bad or wrong thing about economic growth, but the architectural translation of that growth, the imagery of that growth is skyscrapers with curtain walls, glitzy glass and metal. Doesn't matter whether you are in Dubai or in New York or in India or Singapore, that image has somehow become a goal of our urban economic development. I think if you step back and just rationalize, does it really make sense to build glass buildings at 40-degree temperatures without shades? There are so many vernacular, traditional architectural approaches of our civilization, of our different backgrounds, different cultures, that have practiced what has been said, passive design. Just designing to nature and adapting to nature in order to cut back on all the negative impact of us producing all this glitzy architecture, appropriate or inappropriate. Our construction sector around the world contributes 40% of the CO2 emission around the world. I once calculated that amount of CO2 of construction can run 250 Singapore economies. Complete economies, not just construction. That's the magnitude. Despite the green movement in the world, right, and many of us are part of that, to drive green buildings, very efficient green buildings, the fact of the matter is CO2 is still going up. Last year, it hit an all-new high number again. Why? is because of those lessons that we should have learned have not been learned, and as emerging economies continue to develop, they are basically repeating, if I may be as honest as I can, repeating those mistakes that others have made. So I think to step back and honestly look at the criteria, the conditions, climatically, culturally, within each of the jurisdiction is fundamental in talking about saving money, doing the right thing. The saddest thing is that you spend money and then you create the problem and then you have to spend money to solve the problem. That clearly is not sustainable moving forward. So I think that is really the first and most important point I want to make. The second one is really about being kind of innovative and creative in the sense of working together. And this point I know have been made many times. The value chain of the real estate industry is so important. And I'm speaking to all of you, most of you are in the healthcare sector, I believe. You are the clients. You are the real estate clients. So you, with that understanding, to be able to then drive the performance requirements of the healthcare facilities is going to be a very critical one moving forward. Healthcare facilities will continue to consume more and more energy, simply because population aging, certainly in this part of the world, we need more hospital beds, more new technology, healthcare technology, all contribute to the increasing energy consumption in healthcare related. We need to do something really, really dramatic in order to bend that curve. And learn from lessons that we have already been able to demonstrate in other building types. So moving to the kind of performance approach to design would be very, very important. And I think all of you can play a role in advocating for that. Thank you.
Thank you, Prof. Lam. I think I'm going to just head on to Whitney and Ratnesh, both same question. Whitney, to you first, very quickly. On your presentation, when you were talking about engaging the community, what was the hardest thing about, you talked about quick wins, and if we were to really think about how that can actually translate into trust and how that can facilitate, solution building, could you give us an example of how that was actually done?
Okay, building trust was definitely the hardest part of our adaptation process. This particular community had previously been in the Auckland region, so underneath Auckland Regional Council's territorial authority. In 2014, they were moved to the Waikato region, to my region, so had a completely different change of governance group. And with doing that, they also had a change of the district council. As a result of that, they'd pretty much been left behind. In our long-term plans, they are the only part of our region in which, at the regional council level, we don't collect rates to undertake river management work. So that's just simple work like cleaning out a stream when a tree's fallen down to make sure that when the rain falls, that stream doesn't flood. So they felt very left behind, extremely left behind. And that was the biggest barrier that we found. As soon as we started talking to this community, we couldn't just jump straight into saying, this is what the model of what this river is going to do when a 1% AEP flood event happens. We couldn't just start with that because they were just like, oh, hold up. We've got all this other stuff that you need to fix first, or we need to talk about before we can even start about thinking about the next 100 years. Let's think about the now and the current day before we even touch what's going to happen in the future. So that's probably the biggest example that I would have. One of the key things I would just like to quickly touch on is people's tolerability. So I would just like to do a tiny quick experiment. I'd like everyone to put their hands up. Everyone put their hands up. Us included. Imagine you live in New Zealand and you have a long driveway, and that driveway goes across a river. And that river floods once every year for a whole day, and you're stuck at home. You can't get to school, you can't get to work. Do you reckon you'll be able to handle that? If you think you can't handle that, put your hand down. Everyone's got their hand up. Great. What if it happens once every 50 years and you were still stuck at home for a whole day? You couldn't get to school, or your kids couldn't get to school, you couldn't get to work. That's fine. Cool. What about every 20 years? Every 10 years? Some people putting their hands down. That's great. What about if it happened once every 5 years? I'm still putting my hand up. 1 day off work once every 5 years, that's good enough for me. What about once every year? If your kids couldn't get to school for 1 day once a year, and you couldn't get to work 1 day once a year, some people still have their hands up, that's good. What if it happened every single week? Every single week, yeah, everyone's putting their hands down. I once did that with a group of school kids. They were about 14, and some of the boys still put their hand up when it was every single day. They would be happy to stay at home. So how can we come up with plans at a government level without understanding our community's tolerability, understanding what matters most to your community that you're doing this work for? What do they love about their community? What do they want to see more of in their community? And what don't they like in their community? That's the process of the DAP cycle that I talked about, is understanding your community risk thresholds and your own tolerability to the impacts of climate change. Hope that helps.
That was great, yeah. And the reason I was asking this quickly before I pass it on to you, Ratnesh, is when we talk about the healthcare system, we have the same issues. Often you can go around there and tell people in the communities about a new initiative, but if you have a bad relationship to begin with, that's not going to fly. So just something to think about when we talk about operationalizing resilience planning and really working with communities. We need to be able to build that relationship, and this is an example. So from your experience in Sikkim, what did you have to really establish connections with them that wasn't really focusing on the work itself? And if so, if you can give us an example of what challenges were there.
So I can give two set of examples, just quick examples. One is how government worked with the community to facilitate, and then there was a result also. So take an example, the example of the flash flood that I gave. So there is a small town called Chungthang, which is on the way to, it's a first town from the river system. So 10 days before this disaster, I was there and I was talking to the health professional there and the community people there. And recently there was a mock drill by the government, and then the entire town was sensitized that, if this glove happen, you have to vacate this town within 20 minutes. Now, on the day of glove, they did actually vacate the town within 20 minutes, and you can imagine doing this in the mid of the night, around between 2 to 4 a.m., and in a cold mountain town. But then that was the trust, and that was something, a messaging by the government, which was done, and then community was well connected, and then they were able to do it. This is the first example. The second example is, when we talk about community, we usually visualize a village, town, or a society. Even in the health system, there is a community, we can call it, say, health, health community, let's call it. Normally, we visualize in a hospital, it's a doctor, nurses, lab technician, and all. When we started with the Sikkim government and we are finalizing that what actually we need to do, after 2 days of consultation, we came up that, okay, these doctors need to be trained in disaster management, preparedness, and so on. Somehow we had also invited engineering department people, and at the end, one engineering department person comes and says that, this is not going to work. We asked why? Because, you will come and train these doctors, and when disaster happens, they will run to us and tell us that, you fix these things, and nobody is training us. So that was one message, that when we visualize community, we need to be more comprehensive, more inclusive. Even for luckily we have architects and engineers here. So we visualize that such that the entire health system, all the components, even the security guard, police, fire department, maintenance department, everybody is included in our effort. And that is how we can work toward the resilient resilient infrastructure system.
Thank you. I'd like to quickly open up to the audience if you have any questions before we wrap up the session. Do we have a mic?
I thought what Dr. Schwertel had to say about tackling healthcare environments and very high temperatures. That's certainly my experience. I also work in Chad, and I was there last week, and every day it was 42, 43 degrees, and some of the healthcare environments are much worse. Some of them were well designed, 1950s architecture to get the air flowing, but the more modern ones, the worse designed they are. And so the notion of having solar-powered cooling, better design, and I wonder if you and Professor Poe could comment on exactly what you're doing, what it costs, that sort of thing.
Yeah, recently did a scoping review for the WHO in the Western Pacific region on climate resilient health facilities, and we found only 42 case studies or so. So there's a real gap in the literature and the evidence base on this in terms of what we're doing and how much it costs and how effective it is. Most of the climate change and health literature is really biased towards the impacts, and there's less on solutions. And I think this is probably part of the reason why we've progressed so little and so slowly. So the Lancet Commission said in 2015 that climate change is the biggest threat to global health, but also the biggest opportunity, because the solutions have also benefits for health. And they also said that, that we have the knowledge about how climate change impacts health. We have the solutions as well, and they're becoming more and more affordable and accessible. And now it's entirely a matter of political commitment. But I think we have to recognise that was over 10 years ago, or nearly 10 years ago. And now we do have a lot of political commitment. As Renzo said at COP28, the health community, health is very much become the face of the climate change discussion, even at the UNFCCC level. And 82 countries have signed on to the COP26 agreement to make health systems more climate resilient and environmentally sustainable. So there are people in the ministries of health whose job it is to make this happen. Just to go back to your question on what other solutions or what else we're doing and how much it costs, there are kind of hard solutions, which you may be better to speak to because they're around infrastructure. But there are a lot, and supply chain, but there are a lot of what they tend to call softer solutions, which is around policy and education. So sometimes what we're hearing from health facilities as well is we just need more education for our health workforce about the links between climate change and health. The other big area of activity is around early warning systems. And as you said before, we've got a lot of surveillance and monitoring, but often this doesn't actually connect to a signal, and even less frequently does that connect to a response. And I think we need to remember that more than half the population of the world doesn't have access to basic healthcare services. About 1 billion people in the world don't have access to a health facility that has adequate and reliable energy, and more than 2 billion people in the world don't have access to a health facility, well, the health facilities don't have access to reliable and safe water. So before we start talking too much about building climate resilience, we have to accept that we're really not even at universal healthcare, and the health facilities that we do have are very under-equipped to deal with what we already know is happening now and will get worse in the future.
I think you already said it, that there are architectural features that in our traditional climatic responses have proven to work, and they have worked for decades. So there's no need to throw that away. The question is, with the advance of technology, can we further enhance and optimize? Now, we've done a net positive energy building in my school in NUS. It's a 8,500 square meter building, air conditioned, but implementing all the learnings of both the passive and active integration. We were able to reduce the energy consumption by 60%. All energy is provided by the solar PV, which has become affordable now compared to the past. and we are self-contained. It's been operational for 4 years. We have excess energy to run the building 2 years for free. So the question of cost is always about what are you willing to invest capital and the ongoing operational costs. Given the situation with uncertainty, right, of energy cost and carbon tax and all that, those have very direct impact on this midterm, not even long-term, assessment of the return. And the math constantly work out. When we first started, people tell us, oh, it's going to take 10 years. Today, people are telling me it will take 5 years. Who knows in 2 years' time, it may be only 2 years. So I think that's the kind of projection we need to use. But coming back to this question, which I haven't quite addressed, is how do you get the public sector in our building industry? It's a fact. Our codes and standards move very slowly. As the more established and more developed you are, the more it can be restrictive because they make it very complicated. And it is one rule for one system. For the longest time in Singapore, if you are a naturally ventilated building, you have a set of rules. But the minute you have air conditioning, you have another set of rules. You can't mix them because the government say, I don't know what to do if you mix it. So we work with the government in all these exploratory, innovative projects from day one, so that we are in the journey together, testing all the science and the technology, understanding the implication on the rules and regulations, moving from prescriptive-based to performance-based. I think medical people are well aware of performance-based. I think those are the kind of working together, the journey, in order to convince the authorities that this is real, this is workable, and it can be cost-effective. Thank you.
Thank you. Any more questions? We have time for just one last one. Okay. Just to wrap up, I think I will bring this back to the questions that I asked at the beginning, and I think all of you have provided perspectives that will inform those questions as we go on forward. One was, how do you actually prioritize climate resilience when you have other competing priorities? And this is then again context specific. But you also, like Prof. Lam, you mentioned at the beginning, you have to really think about the trade-off and sometimes work backwards further ahead and really look at the cost of inaction. And we need data again to have that informed decision. So again, like you mentioned, Patricia, later on, that there are very few case studies. So we need to really look and contextualize and understand situations with the projections we need for different alternatives. And that's where you can actually do that. But again, to do that in the healthcare system, you need to have allocation of people who are interested in looking at climate impact on health and making those numbers count, right? So that's where we need to begin. And then again, we need to harken back to what Renzo talked about. Shift the perspective from just not being only person-centered, but also planet-centered. What that means is that we need to, again, now talking about my first set of questions, where does a health system actor stop? Is it just about service delivery, or are we addressing upstream determinants? And this ties again to what Prof. Mala talked about. You need to talk about sanitation. You need to look at how it changes behavior. And that has, when you change someone's behavior, it creates new health impacts and not just the old ones. And that is, in a vulnerable community, you're compounding problems even further. And if you don't really if you aren't inclusive, and this is again back to what Ratnesh just talked about, being as inclusive as you possibly can and capturing the different, the nuances between communities, you're not going to really understand, and you're going to miss the knowledge of the problems that they're facing, but also the solutions that they may actually have, which ties into what Prof. Lam again said several times, that solutions don't have to be complex. And while he meant it in the architectural sense, it also applies to everything else that we do. It's not necessary to be overly complicated. So when we're talking about operationalization, bringing the story back to this morning, you need to really talk about the how, the why, and the what, and then inform the policies. Again, talking about, say, the built environment. How people classify things for regulations can have an impact on how people then think about design and solutions. So with that, I'd like to thank you for your time, and the panelists as well. Thank you so much.